Hello and welcome to Psyched, the show where we explore psychedelics through social, economic, and political perspectives. So next up, we have Matthew Johnson. He'll be talking on therapeutic effects of psilocybin. Matthew is professor of psychiatry and behavioral sciences at Johns Hopkins University School of Medicine. He's one of the world's most published scientists on the human effects of psychedelics. Dr. Johnson earned his Ph.D. in experimental psychology at the University of Vermont in 2004 and has published more than 120 peer-reviewed articles. Working with psychedelics since 2004, Dr. Johnson published Psychedelic Safety Guidelines in 2008, helping to resurrect psychedelic research. As principal investigator, he developed and published the first research on psychedelic treatment of tobacco addiction in 2014. Dr. Johnson and colleagues published the largest study of psilocybin in treating cancer distress in 2016. His 2018 psilocybin abuse liability review recommended placement in Schedule 4 upon potential medical approval. He's principal investigator on funded studies investigating psilocybin in the treatment of opioid dependence and PTSD, and LSD in the treatment of chronic pain. In psychedelic research, he also published the first blinded research showing effects of salvinorin A and research examining psychedelic effects on mystical experience, personality change, meditation, and naturalistic addiction recovery. Dr. Johnson is also known for his behavioral economics research, including decision-making underlying addiction, tobacco regulatory science, and drug effects on sexual risk behavior. He has published studies on nearly all psychoactive drug classes. Dr. Johnson was 2019 president of the Psychopharmacology and Substance Abuse Division of the American Psychological Association and is the 2020 through 2021 president of the International Society for Research on Psychedelics. He has received continuous NIH funding as principal investigator since 2009. He has reviewed for more than 75 journals and has served as guest editor on special issues on psychedelics in 2 peer-reviewed journals. Dr. Johnson has reviewed grants for NIH, NSF, the US military, and multiple governments outside of the USA. He has provided invited presentations in 13 nations. Dr. Johnson has been interviewed widely, including by Anderson Cooper on 60 Minutes, Fox Business News, CNN, NPR, BBC, New York Times, Washington Post, Wall Street Journal, and Michael Pollan. Matthew, thank you so much for joining us and welcome to Psych.
Hello.
Hey, how are you?
Hey. How you doing, Merrick? So sounds like I'm ready to roll. So maybe you can clarify. It looks like things are a bit off. Tell me about timing. Do I have a half hour still?
Yep, you have a half hour. We'll run a bit later. So 25 minutes for the chat and around 5 minutes of Q&A, however you want to split that.
Cool. All right. So, and to clear, I assume like we're live now, right? So just keep rolling.
Yeah, you're good, man. We can see you. We can
Awesome.
hear you. You're good to go.
All right. Wonderful. Well, let's see. Let me get some share screen going here, folks. Bear with me just a second. Yeah, that's the one I want. Okay, do you see my screen?
Yep, you're good.
All right, holler at me if a problem. All right, cool. So I'm going to be going over the therapeutic potential of psilocybin. I've done a lot of research with my colleagues over the last 16 years at Johns Hopkins with psilocybin. I can only go over a small portion of that here, but I'm going to try to hit the high points for you. And by way of disclosure of conflicts of interest, I have advisory relationships with Beckley Psychedelics, and Entheogen Biomedical, Field Trip, MindMed, and Otsuka. First, I'll just kind of tell you that although I've been doing research.
Just a quick thing, Matt. If you're advancing the slides, we haven't seen them advance, but I'm not sure if you've gone forward yet.
Okay. Okay, are you seeing like slides change now?
Yep.
Okay,
Now they're
cool.
good.
Don't know how that got off track. Thanks a lot, man. Um, so anyway, catching up. Yeah, so we've been doing research with psychedelics for quite a long time, myself since 2004, but kind of the designation of a center is something that's relatively new since this past fall. Basically got a $17 million investment from philanthropic funds from the Cohen Foundation and from the Tim Ferriss Collaborative to massively expand our research. I'm principal investigators on two studies amongst that growth of work. One is using psilocybin to treat opioid addiction, and one is using psilocybin to treat PTSD. Those studies haven't started yet, but we're on our pathway with all the regulations and whatnot. And of course, things are on a bit of a hold here with the pandemic and all, but some cool stuff to come. I always like to address, I think it's critical to address the risks of psilocybin. I have a number of things in the literature I can refer you to on this. One is a review paper from a couple of years ago analyzing psilocybin in the context of the 8 factors that the FDA uses to examine the abuse liability of a drug under the Controlled Substances Act. And I, for the sake of time, won't go over all of the risks of psilocybin. The biggies, and that are really in contrast to many other drugs of abuse, are that for those who have a predisposition or active psychotic disorders like schizophrenia, there's a risk of exacerbating those disorders if people are exposed to psychedelics. And the other biggie is what folks call the bad trip, what I call in the context of an appropriate environment in clinical research as challenging experiences, which is not a risk in and of itself when the context is right, but you have to have the right mitigation strategy, the preparation, the monitoring, the screening, and the follow-up care. And one area of risk that's notably absent, apparently, from psilocybin and the other classic psychedelics, the other 2A agonists like LSD, DMT, mescaline, is a lack of addiction. So they can be abused, and that's simply means they can be used dangerously, but no one's jonesing for their next mushroom fix. They're not drugs of compulsive drug seeking. And I've early on published these guidelines, which have been recognized by the field and the FDA in evaluating novel protocols. These safety guidelines, really reviewing the older literature going back to the 50s on the risks of these compounds and what you specifically need to do to mitigate those risks. So I won't say further other than to point you in this direction if you're looking for more information on that. But suffice it to say, take safety extremely seriously, and these are powerful tools that require appropriate use. The initial work at Hopkins, we focused on healthy normals, and that's been a continuing thread throughout all of the work that we've done over the years. And by healthy normals, that just means someone without a diagnosed disorder to treat. So one of the things that shook out was that it was safe to give a high dose of psilocybin in people, and with these guidelines that I mentioned. And remarkably, we found evidence of improvements in mood and quality of life over a year after sessions, and not only from the individual, but from co-workers, spouses, neighbors, these type of people who had consented to provide feedback on their participant. So quite remarkable. The second study that we conducted in healthy normals with psilocybin was a dose effect study where we administered a true placebo and then 4 active doses of psilocybin. And we saw a beautiful graded dose-related effect. Across all of our measures, it's safe to say that we saw that when you increase the dose of psilocybin, there was an orderly effect on increasing mystical experience. I'll define that in a minute. And challenging experiences, the so-called bad trip, and long-term attribution. And I'm showing you in the graph here just one of these atypical measures for a pharmacology study. This is the percentage of people at every particular dose that rated the experience as among the top 5 most spiritually significant of their life. So clearly set in setting or context has a powerful role. with these drugs, but so does pharmacology, because under rigorous double-blind conditions, you see these beautiful dose-related effects. Mystical experience I mentioned, that admittedly sounds a bit woo-woo, but it's a psychological construct that's now rigorously measured. And interest in it dates back to William James, the founder of American psychology. And the idea is that across the centuries, from different parts of the globe, from different cultures, people have reported remarkably similar experiences, often from a religious, but sometimes from a non-religious vantage point. And the core factors of that experience, some of them are an overwhelming sense of unity, like feeling one with everything, with the universe, with humanity. For example, positive mood, transcending time and space, and ineffability. In other words, no matter how hard you try, you feel like you're never going to be able to fully describe what this thing was that just happened to you. So we developed there were existing measures of this, more tailored towards examining experiences across someone's lifetime that fit into this category. But we developed the first measure that could be brought to bear on a drug experience or any experimental manipulation. So this measure is the MEQ30. You can find it, and it's been used a number of times in research by our group and others at this point. Across those two healthy normal studies I mentioned, we found that combining the data, that psilocybin increased the personality dimension of openness. And so as far as I can tell, this was the first experimental study ever to actually change a personality dimension using a relatively discrete experimental event. So we know that aging changes personality. Some major life events like having kids, this type of thing, can change personality. But until this, nothing you could, like, for example, schedule for next Thursday was able to change a personality dimension. And what we mean by openness is a broad tolerance for the viewpoints of others, the ability to hold seemingly mutually exclusive ideas at the same time, so thinking in a both and rather than an either or framework, and appreciation for aesthetics, art, beauty, etc. And I'm showing you some data here that even if you parcel out all of the people exposed to a strong dose of psilocybin, it was the people, if you parcel them out by those who had met those criteria and all those domains for having a mystical type experience versus those who did not, even though they had a strong psilocybin experience, it was those who had this mystical experience where we saw a significant increase in personality openness. And you'll see that theme repeat, particularly on our therapeutic measures, that seems to be something special about the nature of the subjective experience, not just having a strong drug effect that determines long-term effects. Now I'll jump into the first of the two therapeutic indications I'll share with you. This one is for cancer patients. This is the largest study that's been conducted using psilocybin to treat depression and anxiety in cancer. These were 51 cancer patients, all had life-threatening cancer. About a third had some type of depressive disorder, about a third had an anxiety disorder, and about a third had a combo of both. Won't get into details, but the nuts and bolts of the study design boiled down to everyone had either like a really trivial dose of psilocybin that was really functioning as a placebo, and everyone had a pretty high dose of psilocybin. And so what we did was we just randomized the order of exposure. Either they got the trivial dose first and then the real dose, the high dose later, or vice versa. Here I'm showing you the outcomes. On the left, I'm showing you the Hamilton depression inventory. On the right, the Hamilton anxiety inventory. These are some gold standard measures for assessing these clinical symptoms. On the x-axis, you'll see baseline in both graphs. That refers to their scores at screening, and you'll just have to trust me that for both of the red and the blue groups, people came in at very high levels. That's what those numbers in the 20s mean. Very high levels of depression and anxiety, clinically severe. Post 1 refers to the time 5 weeks after their first psilocybin session. So at that point, the people who had the real deal, the high dose of psilocybin shown in the red here, saw dramatic decreases in depression depressive symptoms down to the non-clinical level. In other words, at this range of the scale, the person doesn't have any diagnosable disorder. Also saw a very substantial decrease with the low dose group, not nearly as large, still indicative of some problems, but a very significant and large difference between those two groups. And I think the reduction in low dose comes from both the placebo effect, what we call the placebo effect, and also just the very careful preparation and introspection that goes into preparing for any of these sessions. Nonetheless, post 2 refers to 5 weeks after the second psilocybin session. Now everyone's had the real deal. Everyone's been crossed over. So we either had the high dose 5 weeks ago or 10 weeks ago. And so now you can see that for both groups, the average scores were down to that non-clinical level, to those extremely low levels. And so that's remarkable enough to see that at 5 weeks after treatment, but to see that at 6 months, as I'm showing you in both graphs, is truly remarkable. I mean, ketamine has been considered a breakthrough in psychiatry for a single exposure, lowering depression symptoms for a week on average, which is really important and not to be dismissed. But here we're seeing effects from these sessions persisting for at least 6 months. And to be clear, it could be much longer. Our colleagues at NYU recently published data suggesting that over 4 years after these sessions, there were substantial reductions in these types of symptoms. And the same basic I've described, the pattern I've described is roughly the same between depression and anxiety. So these persisting effects. And like the work I showed you on personality openness, we see that the greater mystical experience within the psilocybin session, as noted on the x-axis, was associated with greater reductions in both anxiety and depression. And I don't have time to describe all of them, but I'll just say that this was our work that I showed you, but extremely consistent with a study at about half the dose that our colleague Charlie Grobe at UCLA published a few years before. And in a study of 12 people, and then in a study of 29 people published at the same time as our work, our colleagues at New York University found very similar studies at about the same dose that we used, very substantial reductions, about the same effect size in terms of lowering scores for depression and anxiety with long-standing persisting effects. And then outside of cancer, our colleagues at Imperial College have published an open label study suggesting strong reductions in depression scores in non-cancer patients. So this is sort of, if you will, like regular major depressive disorder, so not in the context of cancer. And I'll say we have recently completed a randomized trial, which we've submitted for publication, also showing that psilocybin shows strong reductions in depression in folks with major depressive disorder. And that holds up to our randomized design. I'll move into our second therapeutic indication. This is smoking cessation. I'll show you first data from our pilot study. It was in 15 people. This is the part where I try to convince you the thing that everyone knows, like smoking is bad. I get to channel Mr. Mackey from South Park. Smoking is bad, McCoy. So you can see here, in terms of deaths, it totally swamps all of the other drugs. All of the illicit drugs are barely visible on the same chart in terms of yearly deaths. And it's even 4 or 5 times larger than the deaths from alcohol. Hopefully by this point, with all the talk of the abuse liability risk and the risk mitigation strategy, you're getting the message that I don't encourage use. There are risks with these tools. I try to learn as much as I can from reports of use. I've done a bunch of work in survey research where people have used these drugs, and that's quite useful to learn from. And but I had to say, the press. This study received some press. That's always a great thing when the press pays attention to science, but they don't clear the photos with us. So although I do emphasize there are dangers and I'm not encouraging use, I definitely want to emphasize to people, most definitely don't do this many mushrooms, because that's a crazy dose right there on that plate. So word to the wise. the people in the smoking cessation pilot study, there were 15 individuals that the important things here, they had been smoking for more than 40 years on average, and they smoked almost a pack a day. So these were not lightweights. We combined it with cognitive behavioral therapy, which is a standard approach to help people quit smoking. It's sort of you assign a target quit date, you have them keep a smoking diary, recording down their thoughts and feelings and the context surrounding their smoking before they quit. You prepare them for what to do if they have if they have a slip and have one, a number of other things, but it's pretty standard stuff. 3 psilocybin sessions over 8-week period, ranging from a moderate to high dose. The first psilocybin session was on their target quit date. Here are the data. This is, I should say, one of the 2 biological metrics to confirm whether they had been smoking or not. This is breath carbon monoxide. It's kind of like an alcohol, breathalyzer for alcohol, but it's for tobacco smoking. And these are the data on the left I'm showing you before the psilocybin session, and these are the data after the psilocybin session. You don't have to be a stats whiz to see you have a pre-post difference there. Abstinence rates were very high long-term. They were at 80% for 6 months after the target quit date. And at an average of 2.5 years after the target quit date, 60% of people were verified as biologically confirmed abstinent. And so that's just far and away higher than what's been reported in the literature. The best medication, for example, the success rates at 6 months are at somewhere in the 30%, 35%. Is a typical finding for varenicline, which is Chantix. We found again that those who had more mystical type experiences during their psilocybin session had greater success in quitting smoking. So that pattern holds up. We're now in the mostly done with a randomized comparative efficacy trial. This involves 80 treatment-resistant smokers. They're randomized to get either psilocybin or nicotine patch. They have the same cognitive behavioral therapy. We scaled down to more for experimental reasons because we're doing brain imaging. We scaled it down to 1 psilocybin session. I still think multiple sessions is better clinically, but we were convinced that 1 session would work good enough, and it makes things a little bit cleaner. Here are the current data. Things could change, of course, and the study continues. It's on a bit of a hold with the pandemic, but 44 people who have gotten to the 1-year follow-up after their target quit date. In the psilocybin group, 59% of people are biologically confirmed as abstinent, and that compares to 27% in the nicotine patch. I have NRT here, nicotine replacement therapy, same as nicotine patch. That's what I mean. So actually very good results for, that's actually substantially higher than what you typically get for even the patch. So it tells us we're doing a very good job in our delivery of nicotine patch treatment. But nonetheless, more than double the success rate we're seeing with psilocybin, and still in that range that's unprecedented in the scientific literature. So it could change, as I said, it's ongoing, but so far it looks like the results are holding up in a similar fashion as our pilot study. We did some qualitative in-depth interviews for the people that went through our pilot study, and we asked them if they thought the psilocybin helped them quit. How did it do that? So some common themes across participants were that it gave them a persisting sense of interconnectedness, awe, and curiosity that helped them quit, that it reduced smoking withdrawal symptoms compared to other attempts. They also claimed increases in altruism and appreciation for aesthetics that were helpful. And they claimed insights into their own self-identity and their own individual reasons for smoking. And I mentioned earlier, our group has conducted a number of studies, cataloging and describing instances of naturalistic addiction recovery after psychedelic use. So this is not from a lab study, but this is thousands of people that have said, oh yeah, I quit smoking after an LSD or a psilocybin experience, or oh yeah, I quit methamphetamine or cannabis or alcohol, or substantial reductions. So we've documented that. It's not as strong as the lab research, but I think and you can't squarely determine causality from these types of studies, but you can look at some relationships, and we found some interesting things in those papers. And I think it's a good complement to our the rigorous laboratory research, because plenty of people say that this happened to them. And sometimes that story goes back. They say it happened 30 years ago that they quit smoking or quit drinking because of a psychedelic, and they're still abstinent. So the big question here is, how in the world does this stuff work? I mean, you should be skeptical of snake oil, the idea that this can work for everything. I don't think it's going to work for everything. My bets are that under the right conditions, psychedelics are going to be promising for a surprisingly large number of psychiatric disorders that involve the need for behavior change. And so I really see the common mechanisms across these nominally distinct disorders of depression and different types of addiction as a narrowing of the behavioral and mental repertoire. I think of all of these, even depression, as addiction broadly defined, whether it's addiction to thinking a certain pattern about yourself or addiction to using a substance. And some emerging data suggests that these various addictions are associated with abnormal brain network dynamics. In other words, patterns in which different brain areas communicate with each other. And complementing that are emerging data suggesting that psychedelics have powerful effects acutely when they're administered in the lab in changing patterns of brain network dynamics. And the big question is, are there long-standing changes after these psychedelic sessions and brain network dynamics? That's something that we're studying in our ongoing smoking study that I mentioned. And I think, even broader than therapeutics, this work points to a real question about what's the endogenous role for the serotonin 2A receptor, the receptor that's the primary site of action for these psychedelics. We don't know much about it. We know they're more expressed in humans than other mammals. We know they're more expressed in mammals than other animals. We know they're major computational units in the central nervous system. I think the role of these psychedelics may be suggesting that serotonin 2A plays a role in playing large-scale modulation of behavioral plasticity, the ability to change, maybe stated another way of modulating meaning or one sense of reality. And kind of another kind of seemingly less scientific way to put some of this is what Michael Pollan quoted me with in his recent book, is the dope slap effect. He said Johnson believes psychedelics can be used to change all sorts of behaviors, not just addiction. The key, in his view, is their ability to occasion a sufficiently dramatic experience to dope slap people out of their story. And I think that's essentially what's going on here, even though, to be clear, there's far more to learn scientifically, and there's no doubt a very compelling biology underlying it. Psychologically, I think this is kind of the story in broad strokes. This field is going to expand massively. It's very apparent at this point. So just some wisdom for the field. You have to use some wisdom. Avoid ideological answers to complex issues. The answers are going to be nuanced. I think this is going to be a new mainstream field of medicine. I think it's important to not pigeonhole these in terms of a certain type of religious experience or a certain type of person. And this is not just for hippies. This is not just for, people of one political persuasion. These are inherent. These aren't just for, atheist or spiritual but not religious. Like, these are human experiences, and I've seen all of these types of people go through the studies, from atheists to political conservatives. I think we need to do our best to frame their effects neutrally and very broadly, while providing very strong, empathetic, and warm human support for the people going through those experiences. And I think we need to cling to those boundaries that we've developed in our various professions, be it medicine, be it clinical psychology. Resist the urge to play guru or priest in the context of these sessions. Yeah. These have been called cultogens back in the 60s. The idea that, one with bad intentions, or maybe unconscious their own bad intentions, that one could use these in a very powerful way, these experiences, to influence people. So we have to be aware of what our own orientation is and really cling to appropriate ethical boundaries. So hopefully doing these things will avoid some pitfalls. But I'm about 25 minutes here, so I'm going to wrap it up. Thank a long list of collaborators and funders for the work that I showed you. And if you want to check out some of our work, go to hopkinspsychedelic.org, and you can find me on Twitter at drug_researcher. So thanks a lot.
Matt, thank you so much. Really appreciate it. Really incredible work, and thank you for taking the time. I'd actually love to, some of the things that you alluded to at the end there, I'd love to get your perspectives on them. I think you've been in this space for quite a while, doing all of this incredible research. Now there are these other entities that are coming into the space, beginning to interact with the research world, based on who you want to work with and who you decide to step away from.
That kind of comes under the bullet point I put up of wisdom. There's no simple answer to that. I mean, one answer would be to avoid anybody who has a commercial interest in this area, and I think that's like way too simplistic. The fact is, no medicine has ever gotten into has been both developed and maintained on the market through a purely nonprofit model, and I think exploring nonprofits is an absolutely worthy venture. And I'm helping with that venture as being one of the investigators on the USONA depression work. And of course, then there's MAPS with PTSD who do great work. But if those models are successful, they're going to do some really great work by making sure that no one's going to be able to go into the market and overcharge for these non-patentable compounds like psilocybin and MDMA. But at the same time, if we're onto something in this field, there's so much room for growth and for experimentation and to go different directions, and you're going to have commercial interests. And so I think, so that's kind of one easy answer that I would encourage people to avoid. That easy answer is avoid anyone with a profit motive in the space. Of course, you always have to be mindful of people's intentions, no matter what context that they're in. There's plenty of examples from nonprofits that in the world that you could point to of bad actors. Also, I would avoid people from falling on the easy answer. I think there's a lot of I've seen this very recently, and it's been growing. The idea that everyone's showing up now, and these aren't the cool kids that were here 5 years ago, 10 years ago, 20 years ago. These interlopers, these newcomers, like, who are they? And if I haven't been reading them, haven't been seeing them on podcasts or on like writing blogs for years about psychedelics, they're up to no good and are to be, there should be some suspicion around them. I mean, we should all use our wisdom in evaluating everything we do in life and the characters we come across, and be open to the data, in other words, stated as a nerdy scientist, but like, what you hear and see and learn about people. But we should be welcoming, new interest in this area. I mean, some people weren't around, or they were like 12 years old, like 10 years ago. I mean, so I mean, this is from someone, I mean, I remember even when we first published my work goes back to 2004. So I've been in this, quite a while professionally. And even at the time when we published our first findings, like, some folks said, oh, well, this work from Hopkins is interesting because I don't think it's not coming from people in the psychedelic community. And I thought, well, what card did I not get? To like, like, is that something official,
Yeah.
just because my name hadn't been out there, so, avoid that too. Avoid, welcome, but use, welcome the new interest, welcome the newcomers, but, use your wisdom. Don't be a fool. So just address two dimensions there of, yeah.
Yeah. Well, one other quick question. There's so many different opportunities, different fields of research, different compounds, different modalities, different ailments to treat. Is there something that you wish you could be working on today that for some reason we just don't necessarily have the infrastructure for you to be working on it?
Yeah, I really wish there was a whole lot more opportunity for understanding the clinical science experimentally beyond just a new disorder. I mean, I can go a million directions with this question. Like, there's so many compounds. Like, getting back, I'm going to be starting some LSD research, hopefully sooner than later. But obviously need to return to older compounds, LSD, mescaline, and move on to newer compounds as well. I mean, there's hundreds, but I think the type of stuff that unfortunately is not going to necessarily get the get the interest or the people to put over money to invest in the work is like just good experimental stuff. What's the best way to support these psychedelic sessions? We're using the same model that was developed in the 1950s of psychedelic therapy: eye shades, music, introspection, high dose, prepare them, but keep your mouth shut as a guide during the session. Works really well. Have we ever compared it in a single study to something else? Have we ever randomized somebody to that versus something else? No. Have we ever, I've got a little bit of data where we randomize what music we used, and it looks like, oh, it doesn't need to be classic Western classical music for this to work. But more stuff in that category. And unfortunately, it's not, no philanthropist is likely to come around saying, oh, here goes $2 million to look at just this question, to look at the role of set and setting, to look at the role of music, to look at, does CBT, cognitive behavioral therapy, or motivational interviewing, or acceptance and commitment therapy work as a better therapeutic backdrop for the psychedelic therapy when you're treating a particular disorder? Like, that's the stuff unfortunately, and I don't see that to be at the top of the list of, commercial investors or philanthropists.
Definitely. Matt, thank you for coming on. I wish we could continue. There's so much more to talk about, but looking forward to chatting more soon. And thank you for your time. Really appreciate it.
Thanks for having me. Take care.
Yeah, bye-bye.